All right. So we're going to get started. So, good morning, good afternoon, good evening. We're It's a pleasure to be here. My name is Javier Sala. I'm actually a cardiologist from Argentina, apart from the LGN. And it's a pleasure to present colleagues here from the US. We have Dr. Shane Mueller, who is the project manager, and we have also Courtney Kraus, who is a research specialist from Kaiser Permanente, Colorado, USA. They're going to be talking about communication ecosystems, utilizing lean principles to harmonize virtual communications across the health system. So go ahead and welcome. It's great to have you guys here.
Thank you so much, Javier, for the introduction. So today, as you noted, I'm Courtney, and I'm co-presenting with my colleague Shane. As you said, we're both from Kaiser Permanente, which is a large integrated healthcare system in the U.S. And we work within the Colorado region. Thank you so much for joining our presentation today on communication systems and how we use lean principles to bring together communications across the healthcare system. Next slide, please. First, we have to acknowledge our colleagues at Kaiser Permanente, Colorado, with whom we've been working on this project and also building off their previous work. It's a team that collaborates across the organization's many different departments and brings together expertise in healthcare system operations, patient experience, and research. Next slide, please. So today we're going to be walking you through how we use the A3 process to work through an issue we encountered at Kaiser Permanente, Colorado, where we knew that patients were opting out of some of our communications about their healthcare. And what we mean by opting out is that they asked to no longer receive some or a number of these messages. And though we had some guesses as to why they were asking about to opt out, we didn't really know yet from the patients themselves. Next slide, please. So to get us started, we're going to go over the background of our problem. And so what we know is these three things about our organization's communication with patients. One, our healthcare organization contacts patients for many reasons related to their health, from keeping clinic appointments to encouraging them to complete lab tests and to fill out pre-visit surveys, as well as to have direct communication with their providers or their physicians, doctors. Two, we also know that we use many channels. And by channels, I mean things like text messaging, phone calls, emails, and letters in order to reach our patients about their health. And that we know that when we often send these messages, or how often we send these messages, can vary quite a bit. And three, many groups in the organization are involved in communicating with our patients, from those that want to send out the messages to those that are implementing or getting those messages out there. And so while we know that messaging brings value to our patients, such as improving their care and to the organization as it provides an affordable and efficient way to communicate, messaging may also be annoying at times for patients and could possibly lead to unintended consequences, like patients saying they want to opt out of these messages, right? They don't want to be contacted anymore. And so this could potentially lead to poor health outcomes. Next slide, please. So in this diagram, uh, we are demonstrating this over communication issue that we're having in our organization, or overproducing. And this has been a long-standing issue without a clear organizational owner, and its contributors and impacts are widespread. And we know that over communication can create other types of waste in our system as well. Next slide, please. So, a bit more about the background of the problem. Since 2015, over 130,000 patients have opted out, meaning they no longer want to receive certain types of messages. And so the ones we are going to be focused on are text messages or pre recorded interactive voice communication. And these pre recorded voice communications are ones where you're not speaking directly to a live person, but someone is leading you through a number of steps on a call. So, say you receive a message that says, press 1 if you want to hear more information about your upcoming healthcare visit. And we also know that only 1.5% of the patients who decide to stop receiving these text messages and pre recorded messages will actually ask to start getting them again. So once we lose them from these messages, it's incredibly hard to get them back to receive this information again, potentially in these channels. Um, so we've looked into this issue previously with some research studies and saw that diabetic patients in particular are more likely to opt out of pre recorded messages compared to overall patients, but that this is an issue that still affects many patients broadly across all health conditions. Next slide, please. So, as it stands today, where our current condition is we know we send messages from many different healthcare departments to our patients via many channels. Again, phone calls, text messages, emails, mailing. And gaining the voice of our customers would help us to better understand their feelings and behaviors around receiving these messages and the choices they make about continuing to receive these messages. And it can also help us to create better strategies for contacting patients. So, for this particular project, we decided to hone in and narrow our scope to Kaiser Permanente, Colorado patients with diabetes who are opting out of receiving text and pre recorded messaging from our health system. Next slide, please. So, to wrap this into our problem statement, this has been an area of unchecked growth and presents an opportunity to streamline and refine strategy and impact. We know our diabetic patients can receive communications from the healthcare system in many ways beyond text messages and pre recorded messages, and that these messages are not sent with a consistent strategy or oversight, which could lead to things like overlap and redundancy or just repeat messages about the same information coming a couple of times. As a result, patients may become annoyed, they might engage less with us, and they might want less of our messaging and ultimately opt out of getting messages altogether. Opting out is a real problem because it can put care and health outcomes at risk for the patient and can lead to poor performance on metrics for our organization. Next slide, please. So, our goal is to gain a better understanding of the patient's perceptions around the organization's text and pre recorded voice messaging to improve our ability to prevent them from opting out. And we decided to do this by interviewing Kaiser Permanente, Colorado patients with diabetes who had opted out of messages. And we also decided to interview Kaiser Permanente patients who have diabetes who had not opted out of these types of messages to also see things from their perspective and compare them with the group that did decide to opt out. And from here, I'm going to hand it over to my colleague Shane to take you through the rest of our A3 process.
Thank you, Courtney. So with this goal in mind of really understanding the perceptions of our patients, we really started by trying to obtain the voice of our customer, our patients. And we did that by conducting qualitative interviews with patients who had diabetes, who had either opted out of these communications recently, and even some who had not opted out. We conducted about 11 interviews with these patients, and we asked them all sorts of questions about their decision to opt out. We recorded these interviews, and we use these interviews to inform our root cause analysis. One thing that we learned right off the bat is that here at Kaiser Permanente, we view our messaging as being channel and origin specific. We see our messages coming independently from each department, and we see them coming from different methods or through different avenues. We thought that these text messages were being received differently than email, or that messages being sent from
Courtney, can you hear Shane?
I
You're
think he
muted.
may have froze.
Yeah, I think he's frozen. Yeah,
Oh no.
well, you can continue telling the story.
Okay. So basically, one thing that we learned is that we view our messaging, as Shane was noting, coming through particular channels and origins, and our members view the messages that come to them as being just from Kaiser Permanente, Colorado, and not by a distinct channel or origin or purpose. We're often sending these messages independently of each of our departments, but that's not how members receive them, right? And this may not be a good indicator of how we are as an integrated system, behind the scenes. I don't think he can. I need to share the slides. Just a moment, please. Sorry.
Don't worry. Go ahead. Look for it. I do have some questions we can go over. So, do you have the presentation too?
I do. It's just going to take me a moment to pull it up on the screen. If I
Sure.
can
Go ahead.
answer
Go
a
ahead.
question, or
Yeah, go ahead. Go ahead. Look for the presentation. Meanwhile, I have a very easy question. You know, you were mentioning, actually, Shane was mentioning that you were contacting patients that had opted out. So, how tough was it for you to be able to contact a patient that had already opted out, saying, "Hey, I don't want any more messages," and now you're
Mhm,
contacting me?
right?
So, was it
Yeah.
easy? Was it a tough quest?
It was, well, I will say that from what I recall, it was a little bit easier than I think we had anticipated. We didn't have a very large group that we were pulling from. Um, but we tried to contact them within a few days of opt out. So it wasn't too far into the, it wasn't like we were calling them even a week beyond when they said they wanted to not talk to us or hear from us in this particular manner anymore. And so uh, keeping
Yep.
it close to the time. Most people were pretty receptive to chatting with us. And I think because we came at it from the perspective of, we just want to learn more about, what issues you're having with our system so that we could potentially, work to make them better for
Exactly.
you and for other patients, that the people who talked to us were pretty receptive.
Yes.
And I think maybe the reason some folks didn't speak with us was really more about just time and not having time in that moment when we called. It looks like
Excellent.
Shane may
Shane
have
is back.
joined
Shane, we
us and
lost
he
you.
can
So
pick up.
go,
I
please take.
apologize. Sorry about
Don't
that.
worry, don't worry, please.
Really
This is what
connection.
happened with hybrid meetings. So go ahead, Shane, and take the stage, please.
Great. Courtney, it sounded like you were providing some additional information about some of these root causes.
I had started that, but we actually answered a question about how hard or how easy it was to chat with people who had opted out. And, I said that most people were pretty responsive actually to wanting to chat with us about this when
Yeah, a
we
lot of
reached out,
them
and that we tried to reach out to them pretty
had
close to
great
time.
ideas too about what we could go from here. So, yeah, as I was saying, a lot of these members reported that they had received messages that didn't feel relevant or particular to them. Some of them talked about receiving messages via multiple channels. So they would receive a message via text message and via email at the same time, or that they would receive the messages over and over again or too often in a repetitive nature. So we heard a lot of different reasons why patients were opting out. A final reason that we heard is that patients were opting out because they were confused about what it meant to hit stop to a message. They might have thought they were trying to stop a message about an appointment reminder, and in reality, it might have been opting them out of all communications. So there was some confusion there as well. In response to what we learned through this root cause analysis, we brainstormed some countermeasures and interventions to try and address this rate of opt out. We, together as a team, worked together to develop these and then map them onto an impact effort matrix here so we could identify which of these might have a really high impact if we implemented them and which ones might take more effort or less effort as well. And I'll review 4 of these coming up here. Again, from that impact effort matrix, we picked 4 possible interventions or countermeasures. The unexpected findings from this project led to further work on understanding and improving what we have begun to call our communication ecosystem and how these all roll up into that. First, I'll walk through some of these countermeasures. One is we tried to reduce the amount of appointment reminders that we were sending to some of our members. We were able to identify members who hadn't missed or our patients who hadn't missed an appointment in the last year, and we reduced the number of messages we were sending them from 2 down to 1. We also looked at combining messages that we would send to some of our patients. So if a patient was scheduled to come in for a laboratory test and also scheduled to come in for a clinic appointment, we worked on combining those messages that we might have sent independently into a single message. We also looked at creating a strategy and infrastructure for evaluating patient communications and implementing those that reflect our regional priorities. So we created a governance and advisory group that really sought to put some infrastructure around bridging the gap between some of these departments that were sending these messages and some of the content that was being sent out. And finally, we discussed revising the language on our text stop prompts just to improve our patient understandings of the impacts of replying with stop. We also, on the back end, created separate campaigns. So when we were sending out messages, if a patient replied stop, they might only stop receiving messages from a particular campaign rather than all messages across the organization. And of course, in addition to implementing some of these countermeasures, we put a lot of effort and thought into how we would evaluate these processes and the results. We see a few of these reflected here on this timeline. For example, from 2015 until recently, we were sending these patients two reminders for every clinic. Beginning in September, we reduced the number who hadn't missed an appointment to evaluate the month period. So we'll be looking at to determine whether that was a successful intervention at reducing opt-outs. You'll also see in April of this year that we created the governance and advisory group, and that's continuing to be ongoing work as we form that and decide how it really handles messages across the organization. And finally, you'll see into 2023 that we plan to implement this new stop campaigns I just described. I should note here is that each of these interventions and implementing them have come with their own challenges and presented their own unique backgrounds and problem statements. Something that we've kind of worked to apply the A3 process, not only process to beat each of these countermeasures as they are implemented. And finally, an important component of the A3 process, applying it to this work, is understanding how to sustain the work. One thing that we've looked at really closely is specific outcome measures that we will really pay close attention to over time as we evaluate the impact of each of these to pivot to other countermeasures as well. For the appointment reminder study and the message bundling or combination study, we're going to be looking at the number of missed primary people who or who received missing more visits as a result. We're also going to look at the rate of opt-outs from these messages. Are they to opt out since they're only receiving one? For the message bundling study, we might also look to see if patients are coming in for their laboratory tests more often and completing those. As we developed the communication governance and advisory group, strategic goals for some of our patient messaging and how they integrate patient messaging that with our organization. And finally, we move to change the way that we are recording our stop messages. We'll be tracking those across the different communications. It's going to really help inform whether to continue with these interventions or to revert back to how we were doing things previously. We've learned a lot going through this operationally communication process system well. Patients were receiving didn't also learn from our patients that they experienced, whether they had opted out of receiving messages or whether they continued to receive them. Both of them had been frustrated at times at the number of messages they would receive, how frequently they were receiving them. We also really learned that there was insufficient communication happening between the teams that were implementing these communication campaigns or sending out these messages. Different parts of our org collaborating as closely to prevent some of that member irritation, that patient irritation. We also learned that the teams who were requesting some of these messages being sent out to patients lacked related to patient messaging. They might have been focused on their specific campaign or their specific message that they were trying to send without thinking more broadly about the experience of our patients and how they might be receiving messages and communications from all sorts of places within their organization. And finally, that our messaging had continued to grow and expand, and it had done so without an evaluation of the positive and negative impacts. And so this process has really allowed us to reflect on that expansion and to think through how to proceed. Not only did we learn lessons relating to our operational learnings, but also this problem. We learned that this is really an iterative process. We uncovered new problems going through this, trying to understand the perceptions of our patients. And those led to new goals, new countermeasures, new ways of evaluating, new ways of thinking. Each was in and of itself. We also engaged with stakeholders differently as the process evolved. The stakeholders changed. We started by engaging identified countermeasures to address needs that we identified. We engaged with different stakeholders, and that evolved as we worked to process. We're constantly identifying new countermeasures that take time to operationalize, to implement, to evaluate, and sustain. I want to thank you all for taking the time to join us today and to learn more about how we apply the A3 process to this communication ecosystem work. And we would appreciate hearing back any feedback or any questions this time.
Thank you, Shane. Thank you, Shane and Courtney, for the presentation. I actually enjoyed it very much. Shane, you were fading sometimes, so a couple of things probably got lost while you were explaining them. So I do have some questions, and there's a great comment there that from Michael Level. He said that he had to go, but this is fantastic work, and he attempts to do a bit here in Maine. So not an easy task. Congrats. Okay, so very, very important. So what were the biggest challenges? Okay, when you were going through all this process, what were for you and for Courtney the biggest challenges?
one of the biggest challenges was really starting with a narrow scope of the problem and understanding it. I think it's really easy when you're looking about at communications across an entire organization to get overwhelmed with where to jump in. As Courtney pointed out, in the patients with diabetes, we really communicate with them a lot. So we really took that as a starting to ensure that they were receiving the best kind of communications they could from us. And interviewing those patients really enlightened us not only to their experience, but the experience of a lot of patients that we encountered. So I think starting with a really narrow scope and narrowing that into a goal was a bit of a challenge, but that really provided us with a very clear vision on the outstart of this, so that we could focus and we could expand from there. But really starting with that narrow, specific goal, I think was really helpful in achieving that. Courtney, do you have anything to add?
I would agree with that. I think that the lean system, the A3 process, right, like really wants you to, bite off a very small task or challenge, right, and work on that. And this one, as Shane noted, just kind of balloons out beyond these very small pieces. And so, yeah, I would say it is pretty challenging to just focus in on one particular group, one particular, even just two types of a message, right? And not expand to what are you getting from email and what are you getting through mailing as well. And to just kind of, yeah, look very closely at one area.
Excellent, excellent. So we have a comment from Peter and also a question. Okay, so Peter said, "Thank you for sharing. This is an important part of health disparities, work not often thought about. Keep up the great work." So thank you very much, Peter, for the comment. And we have a question from Heidi. She says, "This was a wonderful example of a clear lean application presentation to solve a problem. Is there a lot of lean support in your organization? And how many people were involved in this?"
Sure. So there is quite a bit of lean support in the organization. I know that they have different sessions available for different folks in all levels of the company. Shane and I, in particular, in the organization, are part of the research department. All of the Kaiser Permanentes have like a little group, and they're not always little, of researchers who work alongside the operational parts of the organization. And that actually, so a couple of the folks who we put in the acknowledgement. So Shane and I are working with Dr. Amy Duckrow and with Dr. John Steiner, who are helping to lead this particular project. Amy in particular, as Javier worked closely with Amy. And you might even, Javier, be able to speak to some of that work together. But we also had some help and input from an individual named Carrie, who in particular works in this area of operational excellence and applying lean. And so we've had quite a bit of help in this particular area. But then in terms of the stakeholders who are working on this project as it kind of gets larger and balloons, there's so many. But we've had really great feedback and interest in this work that we're doing. And folks are seemingly on board for, some of these changes.
That is great. That is great, Courtney. So we only have 1 minute left. So I'm going to close saying, first of all, thank you. Thank you for all the great work you're doing. That means a lot for patients. And you're touching, diabetic patients. We need to be in contact with them. We need to be close to them. It's a tough disease that, it's a chronic disease, and it actually is very important for them to be able to have the better care, that we can give them. And the second thing I want to say is that communication is a huge issue. Okay, it's one of the things that it's not easy to have, and you have a great big system. Okay, so being communicated from all the different departments and trying to target everything and together is a big challenge, but you are doing a great job. So congratulations and keep up the great work. Okay. Thank you very much for presenting. It was a pleasure to have you both here representing Casa Permanente from Colorado.
Thanks so much, Javier. And thanks everyone for attending.
Bye bye.